Periodontics to the rescue. Welcome to this episode of Orthodontics in Summary. In this episode, we'll be looking at the orthodontic periodontal interface, specifically looking at where orthodontics can be the cause of periodontal defects to emerge, and also looking at what periodontal surgery can offer. This podcast episode is a summary of an excellent lecture given as part of the AngleNet Webinar Series by Christos Kassaro and Anton Spurrier. Looking at where orthodontics can be the cause of periodontal defects are two key components, that of active orthodontic tooth movement as well as during that retention stage. We look at first the study from last year, from Christos in 2025. It was an excellent one-year follow-up study, looking at adults who had undergone orthodontic treatment, looking at an assessment of their periodontal status at the end of treatment and a year down the line, and comparing that to a control group. And what they found was the orthodontic group had 67% greater incidence of recession when compared to the control group. They broke that information down and showed that generally these defects occurred in the canine and first premolar region. So in the middle of the arch, and I think that's an important take-home message. We tend to focus our attention on the incisors, but actually it's the corner of the arch which seems to undergo the most likely recession from orthodontics. Proclination didn't seem to have a role, with proclination of 6 degrees not being seen as an indicative factor for recession. Now, what I thought was interesting is that in the recession group, in the control group, recession still took place. And I think that's really interesting to note. It is that there is more recession in the orthodontic group, but still occurring in the general population at large. Recession seemed to be relatively small at the 1 year mark at approximately 1 millimeter. And that really begs the following question. What has actually been the role of orthodontics in the process of recession? Has it set off a cascade process, unzipping the periodontium, causing the tooth to come to its demise? Or simply has orthodontics just accelerated the rate of recession for a certain number of years, but actually is relatively stable? And that brings us on to the next study, which is by Gabistorov in 2018 from the same Swiss group. They looked at patients 15 years down the line and looked at orthodontic patients compared to controls. And what they found was that the orthodontic patient typically had 77% of 1 to 14 areas of recession. Now, it's important to know that the control group was at 62% for the same parameters. So a 15% difference in terms of the quantity of recession defects, which overall doesn't seem to be seismic between them. Where did this occur? It generally seemed to be more on the lingual aspect than the label. Again, probably a key take-home message from this podcast is that we need to start looking at the premolar and canine regions, but also looking at the lingual aspect when assessing recession. So which variables seem to cause greater recession than others? Well, there were two key things. The first was that of patients who had a crossbite to begin with and had expansion for its correction. That was 2.7 times more likely to have an experience of recession. So though transverse correction seems to be advantageous from a malocclusion perspective, we may be predisposing patients to another type of defect down the line. What was really interesting was the control group had a variable which increased the level of recession, and that related to crowding on the incisors. 3 millimeter crowding or greater, patients were 3.2 times more likely to have recession which occurred. That's a real good take home for us to have in terms of looking at our patients and warning them significant crowding can result in greater recession down the line and dental health benefit from achieving alignment. So it doesn't look as though orthodontic treatment itself impairs the longevity or function of teeth. But where there is variability in the literature is that does it compromise the aesthetics through this greater quantity of recession for our patients? Retention. When we talk about braided stainless steel wires, we have the adverse effect of unwanted tooth movement, the so-called X effect, resulting in torquing differences between teeth, as well as a twist effect, resulting in proclination. Now, this isn't relapse in itself, it is new movement due to the unraveling of the arch wire or activation of it. Fortunately, this is relatively uncommon at 2.7% of the population, according to Rainkeimer's 2011 study. Now, the ways to manage it involve having orthodontics and potentially periodontal surgery as well. What I really loved about the way the authors described the mechanics, they didn't describe putting in torque simply into the arch wire. They spoke about using alternative slot sizes. Simple mechanics, the use of an 18 slot on the tooth that's affected. For example, it's got lingual root positioning. A minus 17-degree torque can be used on that individual bracket. Now, the adjacent teeth are 022 slot sizes with 0-degree torque. And I think that's a really intuitive way to achieve reliable torque expression working through nickel titanium and stainless steel arch wires. What I loved about the authors is that they also mentioned the side effects of this. Yes, there will be a difference in the vertical positioning through transitioning between different slot sizes, and there will be a small intrusive component which needs correction in detailing. We don't always need to have surgery carried out at the end. It should be reassessed, and there may be some bounce back in terms of periodontium. I think that lets us know there are significant variables in terms of orthodontics and the effects it can have in terms of correcting a defect when it's iatrogenic. What about surgery? Well, when it comes to surgery, what are our key principles in terms of its management? Well, the first is the indications. When there is inadequate soft tissue, how is that defined? Well, according to the periodontal consensus statement from last year by Zong, it is less than 2 millimeters of keratinized tissue. The key principle of surgery is wound healing. If wound healing is quick, if wound healing is stable, therefore the flap and the graft is more likely to be successful long term. Flap design can influence that process of wound stability and healing. The key thing is when it comes to incisions is to avoid vertical incisions, to consider using biological materials, which I'll touch on later on, and also to have a tension-free flap in the technique that's used. Now, the most common site to harvest the graft is from the palate, and the reason why the palate is so favoured is because of the sheer abundance of soft tissue which is available, lending itself to different techniques and processes. A large quantity of keratinized tissue which is present, but also very quick healing of the donor site takes place in terms of our patients. So in terms of wound healing, the first 3 weeks are the most essential to maintain optimal oral hygiene, but also to ensure that the blood clot remains stable. And that relates very much so to the sutures being present and also the graft area not being disturbed during this particular phase. 2 types of surgery are described: full thickness and split thickness surgery. What are the differences? Well, a full thickness includes the entirety of the tissue. That's the mucosa, connective tissue, as well as the underlying periosteal layer. A split thickness is thinner, just the mucosa and the connective tissue, needing the recipient site to provide the blood supply from the periosteum. Now, the 2 techniques that are most commonly discussed are the modified coronal advancement tunnel, and this is described by Allen in 1994. So this is essentially for multiple areas where we are raising the periodontium in general in terms of its height. It's a combination of both of these concepts of full thickness at the papillary region and a split thickness at the apical region. Surgically, the advantage that it has is that there are no vertical releasing incisions. That really helps keep the tension down and stops any strain taking place during the healing phase. Great vascularization because we have got a full thickness as well as a split thickness approach taking place, and tissue blending works out really well. Now, there's a second technique which is the lateral closed technique, or the LCT. Now, this relates to a single vertical deep recession defect. Now, for this, the tooth has to be positioned well within the alveolar bone. A full thickness tunnel flap is raised off the entire length and is then sutured back in a tension-free way to cover up the vertical defect which has occurred. Well, what should the timing of the surgery be? Well, that is a big question. And there are 2 answers as we'd expect from this, depending on the circumstances. In general, surgery is carried out after the orthodontic movement. And the rationale given here comes back to that key principle of surgery, idealizing the environment for wound healing. If the tooth is placed in the ideal position of the alveolar bone, well then actually the periodontal tissues are more ideal in terms of the taking of the graft into that particular site. Now, surgery, of course, can be done before orthodontics as well, but this pertains more now to the orthodontic need, in terms of being able to advance incisors, for example, and enabling tooth movement to occur, pending on the patient's periodontal phenotype. We know for the thinner phenotype, or the thin scalloped phenotype, as D. Rook described in the classic paper in 2009, we know that those periodontal phenotypes are more likely to undergo recession and less resilient towards proclination occurring. What about the adjuncts to surgery? Well, there's different things that have been described. One of those is the use of amylogenins, a regenerative material, described as increasing the rate of wound healing and enabling proteins to come to the site. The downside this material has for all its ideals is that it requires the site to be blood-free, which is challenging to do in terms of the surgical process. This is where hyaluronic acid comes in. It's a relatively hydrophilic material which promotes proteins to the site and therefore enhancing wound healing occurring, and is now being used as an adjunct in terms of periodontal trends associated with surgery. Now, one of the questions that was asked, which I thought was really interesting, is that when we see roots which are outside of the bone from our radiographic assessments, do these teeth need to be root canal treated? And the answer was, well, no, because actually the movement of the tooth has been relatively slow in terms of iatrogenic orthodontic movements, and it hasn't been moved quickly, and therefore the blood supply for the tooth has been displaced. The likelihood is that the tooth remains vital even in that particular position. The advice was not to electively carry out a root canal treatment on this tooth just because it appears to be outside of the bone from the radiographic assessments. A quick update for me, looking forward to this Saturday for our Orthodontics online day 1 with my colleague Assam Al-Kademi. Next week I'll be in Brussels with the European Aligner Society. I'm delighted to be collaborating with them this year, working on a To The Point podcast 4 series episode for the delegates, as well as a wrap-up at the end of each of the 2 days of the conference of describing the key findings from the day's lecturers. Really excited to be in Brussels next week and look forward to seeing you there. As always, please do subscribe and look forward to the next episode.